Osteoporosis. Osteoporosis is a chronic disease where the bone density is lost because of multiple factors. Bone constantly undergoes changes or remodeling through cellular regulation, and it occurs when bone reabsorption occurs at a greater rate than bone building activity, and this will result in bone mineral density loss. Osteopenia is going to be a loss of bone mass that occurs prior to osteoporosis. It's often not diagnosed until a fracture has occurred, but be aware that with osteoporosis that a fracture may occur before the fall. It is underdiagnosed and therefore it's undertreated. 50% of all postmenopausal women and 25% of men over the age of 50 years are going to suffer a fracture due to osteoporosis. It occurs in about 1 in 10 people over the age of 50 in the United States. That's a pretty high number. Risk factors for osteoporosis include being over 50 years of age, menopause, or a total hysterectomy. Now, if the hysterectomy leaves the ovaries, then osteoporosis is not necessarily a risk factor at that point. Parental history. White or Asian ethnicity has a higher risk. Eating disorders, rheumatoid arthritis, a fracture history after the age of 50 years, a low body weight with a thin frame, low calcium and or vitamin D intake, estrogen or androgen deficiency, smoking, whether it's active or passive, a high alcohol intake. There's certain medications that can lead to an increased risk of osteoporosis, such as a chronic steroid therapy. Poor nutrition, not just malnutrition, and lack of physical exercise or prolonged immobility. Generalized osteoporosis involves many structures in the skeleton. Now, when we talk about primary osteoporosis, this is the most common type. It occurs in postmenopausal women and men who are in their 70s and 80s. It's caused by a combination of genetics, lifestyle, and environmental factors. Some of the things that increases the risk of calcium loss would be excess caffeine intake, causes us to lose a lot of calcium in the urine. A lack of calcium in the blood will trigger the parathyroid to release calcium from the bone. Vitamin D is required for calcium absorption, so if we have a low level of vitamin D or we don't get a lot of sunlight, then the calcium that we take in may not be absorbed. A high phosphorus intake also leads to the loss of calcium. And did you know that soda is very high in phosphorus? High protein diet can lead to calcium loss in urine excretion. However, protein is required for the body to be able to use calcium. So we need that good amount of protein. We just don't want it to be too much. Secondary osteoporosis will result from other conditions such as hyperparathyroidism, long-term drug use such as steroids, and prolonged immobility. And then we have regional or localized osteoporosis. This occurs when a limb is immobilized related to a fracture, injury, or paralysis. It can also come from decreased mobility for longer than 8 to 12 weeks. And it can also occur in a gravity-free or weightless environment for a prolonged time. So think about the astronauts on the space station who have been there for an extended period of time. Osteomalacia is basically a softening of the bones from bone loss due to a lack of vitamin D. Now, people do confuse osteoporosis and osteomalacia, where osteoporosis, we have a decreased bone mass that is caused by multiple factors. The osteomalacia is basically just a softening caused by a lack of calcification. We have a lack of calcium, estrogen, and testosterone with osteoporosis. But with osteomalacia, this is basically a lack of the vitamin D. With x-rays in osteoporosis, we're going to see the osteopenia and potentially fractures. With osteomalacia, fractures. The lab values of calcium phosphate, parathyroid hormone, and alkaline phosphatase in osteoporosis are going to be calcium lower normal, phosphate normal, parathyroid hormone normal, and the alkaline phosphatase is normal. However, with osteomalacia, we have a low or normal level of calcium, low or normal level of phosphate. The parathyroid is high or normal, and alkaline phosphatase is high. So, what might we see and how do we assess a client who we suspect of having osteoporosis? Well, first of all, it's really important that we determine the risk factors this client may have. And we've already listed those risk factors. And we should also do a fall risk assessment. Now, if these clients fall, they are likely to have a fracture due to that decreased bone density. With the physical assessment, we need to be inspecting the vertebral column for abnormal curvatures. You know, that humpback is called kyphosis. It's that outward curvature of the spine that creates that humpback. We also need to obtain a height and compare it with previous measurements because as we get older, adults can lose up to 2 to 3 inches of their height. We should also assess for back pain that worsens with activity and improves with rest, that may be accompanied by tenderness and voluntary restriction of spinal movement. This could potentially indicate a compression vertebral fracture between T8 and L3. This is one of the most common osteoporotic fractures. So with osteoporosis, we often see compression fractures. Decreased mobility might lead to constipation, abdominal distension, reflux esophagitis, and respiratory compromise. It's important to assess for all areas that are painful. Assess for signs of fractures such as swelling and malalignment, especially in the distal end of the radius and the upper third of the femur. We also should do a psychosocial assessment. There is a decreased quality of life due to pain, insomnia, depression, and fear of falling with osteoporosis. The client may have an altered concept of their body image and poor self-esteem, especially if the osteoporosis is beginning to cause some postural changes. There might also be a limitation of social or physical activities due to anxiety and that fear of fracture. During our assessment, there's some labs that we're going to get that would be specific to osteoporosis, and that would be a serum calcium and vitamin D level. We could also do some of the bone turnover markers to help monitor treatment, not necessarily to diagnose, but to monitor treatment. As far as imaging goes, we can do traditional x-rays, but to really determine if there is a loss of bone density, we do that dual x-ray absorptiometry, also known as the DEXA scan. As far as priorities with these clients, they're at a priority for potential for fractures due to weak, porous bone tissue. So, what do we do? Well, we want to start with prevention, and this begins with education. We should decrease modifiable risk factors, and this would include improving calcium and vitamin D intake and sun exposure, of course, avoiding sunburns, smoking cessation, avoiding excessive alcohol intake, stressing exercise importance, especially weight bearing exercises. That weight bearing exercise is going to help strengthen the bone, but avoid jarring exercises such as jogging, horseback riding, which could lead to potential fractures. We need to educate on nutrition therapy, lifestyle changes, and drug therapy. These are all used to slow bone reabsorption and form new bone tissue. That self management education can help prevent osteoporosis, or if the client has been diagnosed with it, to slow the progression. As most clients are managed at home, education is going to be vitally important and includes the topics listed here. With nutritional therapy, again, we need to encourage that adequate calcium and vitamin D intake, avoiding excessive alcohol and caffeine. Evaluate the client's ability to be able to purchase appropriate foods and liquids. Some of these foods might be a little on the more expensive side. And always consider consulting a dietitian or helping the client develop a nutrition plan that contains fruit and vegetables, low fat dairy, protein, fiber, with a moderation in alcohol and caffeine. As far as lifestyle changes, exercise. Exercise can help strengthen the abdominal and back muscles, increase lung capacity, improve mobility. But weight bearing exercises, such as walking 30 minutes 3 to 5 times a day or weekly, is going to be the most effective osteoporosis prevention. Now, it doesn't have to be 30 minutes all at one time, it can be broken up into 15 or 10-minute intervals. And again, avoid those jarring activities to help prevent those vertebral fractures. The client should also avoid tobacco in any form. As far as drug therapy, calcium with vitamin D supplement, biphosphonate, which is the most common osteoporotic drug to be used or to be used for osteoporosis, an estrogen agonist or antagonist, the parathyroid hormone inhibitor, and a sclerostin inhibitor. And then, of course, we should refer the client to the Bone Health and Osteoporosis Foundation that's located in the United States, and in Canada, the Osteoporosis Society of Canada. As far as evaluation, it's going to be based on the identified priority client concern. So whatever is the biggest issue going on with this client, that's what we're going to base our outcomes on. But we need to make sure the client continues to follow up with DEXA screenings. In other words, it's not one and done. They need to make sure that treatment is helping the situation and not the client isn't continuing to deteriorate. We need to make sure the client has made lifestyle changes to help prevent further bone loss, and make sure the client does not experience a fragility fracture. And that fragility fracture would basically be the osteoporotic fracture due to that decreased bone density and the weakened bone.